In just a second, we'll have PowerPoint.
Let's see.
Exciting.
I'm gonna go off camera when it's not my part, just because it helps to declutter.
Yeah, no worries.
And I hide my video too, so I might disappear.
It's fine. I'm gonna go ahead and share my screen now. I'm assuming we can all see that. Okay, before I begin. Alejandro, we're good to start?
Yeah, I think we're good. We can
Yeah.
see your screen.
Okay,
Mhm.
I'll start. Okay, well, welcome to the LGBTQIA plus Cultural Competency in Healthcare Workshop. Thank you to the organizers for HDR at UCR for making this session possible and for keeping it running smoothly. Thank you to my co-facilitators that I'll be introducing in a minute, as well as myself, for bringing years of experience in queer community-centered health to the table. And thanks to everyone in attendance and for making this possible. The overall mission of this workshop is to equip attendees with experience-informed approaches to providing affirming and culturally competent clinical care for diverse LGBTQAI plus communities, as well as provide a roadmap for applications of this knowledge in social science research on health and caregiving practices. Due to discrimination, violence, and institutional ignorance concerning LGBTQIA plus health disparities within these populations, many of these disparities are rampant and very complex, and these disparities are further compounded by the effects of structural racism, which will be a central focus of this workshop. Community engaged research can play a role in amplifying narratives of experience and bring needed attention to the overlooked and marginalized groups. It is our hope that you will all walk away with a specific call to action in regard to reducing barriers to health and vitality for LGBTQIA plus people. So as we begin to introduce myself, I am Joshua Liaschenko. I'm a PhD candidate in anthropology at UCR. I'm also a graduate student researcher with HDR at UCR. My area of expertise is in medical and queer anthropology with an emphasis on gender, health, and caregiving practices within vulnerable populations. My current dissertation research focuses on how the inclusion of professional healthcare providers who are trans and/or non-binary works to mitigate trans health disparities and build capacity for community-driven advocacy and care across Southern California. So my work centers on trans and non-binary providers, biomedical providers, as well as mental health providers across Los Angeles and Riverside counties. My work examines how experience-informed care interacts with LGBTQ activism, institutional and community loyalty, as well as cultural and medical discourse concerning the lived experience of trans and non-binary people. I also want to introduce my co-facilitators today. First will be Sunny Meador. Sunny has served as behavioral health manager with TruEvolution since 2014. They started as the lead community organizer, building and creating community partnerships. They later became the director of programs and assisted in the development of the behavioral health department, joining as the care coordinator. They were later promoted to their current position of department manager, where they oversee client onboarding and management, clinician schedules, department presentations, department billing, and other tasks like participating with all of us today. They are currently a Master of Social Work student at Simmons University with an aspiration to be a licensed clinical social worker with an emphasis in trauma. My other co-facilitator is Jake Krastovski. Jake is a licensed psychotherapist and works with the LGBTQ community, primarily trans individuals. Jake was born and raised in Los Angeles and came out as trans at age 13. Since then, he has dedicated a large portion of his life to fighting and advocating for the community, and helping create safer and more inclusive spaces. Jake is the chair of the City of West Hollywood Trans Advisory Board and the founder of the nonprofit QueerWorks, where he works to provide affordable, accessible, and affirmative mental health services to the LGBTQ community. To start us off, I want to provide everyone with a brief introduction to some of the terminology that is relevant to healthcare and social science research among LGBTQIA+ populations. After that, I will turn it over to my co-facilitators and step back in towards the end to discuss applications for research. Before I begin with my PowerPoint slides, I do have a brief caveat. The terminology surrounding gender, sex, and sexuality is always in a state of flux and contestation. The definitions and insight I'm about to provide may have different meanings for community members, but it is my desire to provide all of you with a working vocabulary that is informed by input from Sunny and Jake, as well as the work of scholars and theorists of gender and sexuality. It's definitely happened to me before where I've written an abstract for a conference presentation using accepted terminology that was accepted at one point in time to find out 9 months later that terminology is shifted in use. And all of a sudden the title of the presentation is somewhat outdated. So I always have to provide that caveat whenever covering this type of content, just to cover all my bases in case people have different understandings of some of these terms. But I do try and be as inclusive and general as possible. So how we understand the word sex, assignment of female, male, or intersex at birth, often based on genitalia and or other biological factors such as chromosomes, can be incongruent or congruent with the person's gender identity. How we understand sex is influenced by cultural perceptions of gender. Gender comprises sociocultural roles, expectations, and internal subjectivities often associated with sex. Gender is a composite of historically and culturally informed performative actions designated as either feminine or masculine or other, and constituting what it means to be man, woman, or another gender. Sexual orientation, the way that I understand this is it's a way that our bodies are oriented. So really deploying the term orientation in how we experience emotional, romantic, and or sexual attraction to other people. Gender identity is separate and it's a person's internal sense of their gender. This may or may not match with their sex or cultural expectations of gender. It's also important to recognize that sex itself is culturally constructed through the lens of genders, and like gender, sex is also operates on a continuum, not a binary. Cisgender, cis, or meaning on the same side as, this term is used for people whose gender identity is congruent with their sex assignment at birth. Transgender, a widely accepted and inclusive umbrella term for people whose gender identity differs from the sex assigned at birth. Trans is an appropriate abbreviation, and you will see the abbreviation TGNB, which refers to transgender and non-binary, especially in our presentation materials where both overlapping groups are being evoked in the same presentation of information. Non-binary, a label used for people who experience gender identity beyond binary categories of man and woman. This is not the same as transgender, but some non-binary people also claim the label of trans or transgender since they do not identify with the sex assigned at birth. It really just depends on the person and the terms they seek to deploy in referencing their subjectivity and experience. And then what we often refer to as alphabet soup, and the letters in our title today: lesbian, gay, bisexual, transgender, queer. Queer is a community use term. It's a reclaimed term from its original uses, or at one point in time use as being a disparaging term, reclaimed among people who are non-heterosexual and or non-cisgender to indicate gender and sexuality experiences that exist out of cis/heteronormativity. And then asexual, misunderstood term that's also operates on a continuum. There are various experiences of asexuality, often referred to as the ace spectrum, that can include people who do not have or do not desire to have sexual relations with other folks, to other people who are on the same continuum, on the ace continuum, that might include elements of sexuality within their lives, but those elements might be considered, quote, non-typical compared to other sexual people. And then intersex, category reflecting individuals who are biologically outside of binary sex. This can be due to what are considered non-typical male-female genitals or anatomy at birth, or chromosomal intersex variations beyond XX and XY. Then the plus that often finds itself at the end of LGBTQIA indicates an acknowledgement of more and newly emerging gender and sexuality categories or subjectivities beyond what was already listed in the rest of the alphabet soup. These slides are available in the supplemental materials, and I also included a slide of references because I am an academic and I cannot help but always include references and stuff that I give to audiences or any work that I produce. That being said, I do want to turn over today's discussion to, I think we're going to be starting with Jake first. And I know Jake has slides himself. And then we'll turn it over to Sunny, and then I will eventually pop back in towards the end. We can talk more about the applications for research. So Jake, if you want to take it away, be my guest.
Hello, everybody. Let me just go ahead and share my screen really fast. So bear with. Here we go. Share. Perfect. Can you see my screen okay? A little head nod. Awesome. Thank you. So I'm going to talk a little bit about what it's like working as a provider, both as someone who is trans themselves, but also a provider, a mental health provider, as Josh mentioned. And I'll tell you a little bit about me in I think, the next slide. Oh, hold on. Got to click it. There we go. All right. So hello, my name is Jake Krastovski. I use he, him, his pronouns. I'm a globally known advocate. So I've been doing advocacy work, especially in the trans community since I was 15 years old. So a little bit over 16 years. So you could do the math about how old I am. So a little joke. I'm also a licensed therapist. I've been licensed within the last year, and I'm a facilitator who my job is to kind of bring diversity, inclusion, and awareness around the trans and non-binary community. So I've worked at like NBC Universal, BuzzFeed, Kaiser Permanente, Cedars-Sinai, all these different places bringing D&I. I've been out since I was 13. And so I use a lot of my personal experience to influence topics around the community. Hold on, let me hide. Hopefully you guys can't see when I get my messages popped up. Okay, so let's go in to the next section. All right, so I want to talk a little bit about an experience and a client's experience, and I'll just say the client is me. So I'm not giving away any personal information about any of my own clients. So I want to talk about being trans. So I was born female, signed female at birth, and I've transitioned to male. So I've had chest surgery, I'm on hormones, I've had a hysterectomy, all different types of surgeries, gender affirming surgeries. I don't really go to the doctor anymore for anything having to do with being trans, right? If I'm sick, it's usually I go in and it's because I have an ear infection or it's because I've broken a bone. And one day, not too long ago, maybe August, so this is recent, August 2020, I was having a kidney stone. And I get them a lot, but this one I knew I needed to go in because I couldn't pass it. So when I got to the hospital, I'm not going to say which one, but it's a pretty big organization. I walked in and because it was COVID, I couldn't bring my partner with me, who I usually bring as a partner advocate or a patient advocate. And I needed to be brought into the emergency room. During that time, I didn't disclose I was trans because I was hoping that it would be brought up because of my medical records, right? Because I've asked to have it put in there many times. And eventually when they got to me and the doctor came in, he started talking to me and I kind of knew that he was assuming I was male at birth because he was talking about how it was going to pass and it was going to really hurt because it had to, come out of my penis, which I didn't have. And so I had to advocate for myself while I was in pain. And when I came out as being trans, he was very flustered, didn't know what to do, and kind of panicked. So while I'm hopped up on morphine, right, because I'm passing a stone, I had to sit there and go into a trans 101. In addition to that, a bunch of random doctors and nurses kept visiting my room for no apparent reason other to fidget with a machine. And I do understand enough of multiple languages to hear people talking about me in other languages and knowing, I heard clearly that person used to be a woman, or that's a trans person, or, oh my gosh, right? So these people were coming into the room just to see me. So that was an experience I had. It wasn't a very good experience. I left, I decided to discharge early and pass the stone at home because it was safer for my own mental health. And when I followed up to make a complaint to this organization, they basically said, sorry, there's nothing we can do, and good luck next time. So with that said, I want to move in to the fact that I'm not alone in this experience. So I did a community-based survey, and out of about 365 participants, 89% stated that they've had adverse experiences with healthcare providers. And then only 40 of these said that they felt safe to be out to at least one person in their life, okay? And so that provider relationship was usually the only relationship that they were out to. So imagine you're out to your doctor and your doctor is still not affirming. That's an issue. 78% of these individuals were trans and non-binary, which is why I'm going to focus mostly on that. And biases among healthcare professionals towards LGBTQ plus patients are extremely common. So don't worry if you don't get all this. My slides are going to be posted and you can read this in more depth. Because of stigma, LGBTQ plus individuals face disparities in physical and mental health outcomes. And you can imagine, right? It's because they don't want to go to the doctor. They don't want to go to therapy. Some of these are rates of anal cancer, asthma, cardiovascular disease, substance abuse, and suicide. This is largely in part to delaying or avoiding medical care because you have experiences with adverse, you have adverse experience with doctors who aren't affirming. So let's talk about the trans and non-binary community specifically, because that's my community and that's who I know most about. So trans and non-binary clients aren't just facing health disparities, okay? So when they come in to get medical services or to receive mental health treatment, they're also coming in with all these other statistics. And I'm not going to go through all of them because you're going to have the slides, but I want to point out a few that are really important. So 47% of TGNB individuals have been sexually assaulted in their lifetime, okay? That's a really large number. And imagine when you're sexually assaulted and you already don't feel comfortable going to the doctor, or you don't feel comfortable going to a mental health practitioner, okay? You don't get treated, right? So that's a big issue. We've also know that 27% of trans and non-binary individuals have been fired or not hired, denied a promotion due to their identity. So a lot of trans non-binary individuals have issues obtaining healthcare because they don't have jobs. So they have to go to places that are definitely not trained or aware of trans and non-binary affirmative care. So blockage to care, right? So these are just a few that I think are really important to point out. And it's also important to point out that what white trans individuals go through, trans individuals of color have almost 3 to 4 times amount more difficulty obtaining safe services. So in this survey that I did, here were some statements that stuck out. I'm just going to read one for sake of time, but this one that I really thought was mind-blowing was that someone was suicidal and they wanted to go to the hospital to get treatment, and all that the hospital wanted to do was ask them what parts they had. And so they felt humiliated and they left. So imagine coming to a hospital. It's brave enough to come to a hospital to be 5150, to be, to have intake into a mental ward, and someone's asking you what parts you have. Would you stay? Probably not. So I think that's a really, really important one to read about. Also, resources are super scarce when it comes to the trans and non-binary community, especially trans and non-binary individuals of color. Low-cost clinicians are super hard to come by. So when we look back at that old statistic and we talk about how there's a high rate of unemployment, services, paying for out-of-pocket services are kind of not an option. So it's really rare that you'll be matched with somebody who is trans affirmative at a free or low-cost clinic, and that you have a safe relationship. Our community stays really hidden, so sometimes it's difficult to find ways to get resources directly to us. And then with COVID-19, already established resources have been cut or they are now inaccessible. So that's a huge thing. So we burn out really easily and we do not have the ability to self-care. So going and doing activism work and advocating for our needs are really difficult. And then a little bit of data stuff. So mental health and health disparities for the trans and non-binary community is super researched and underreported. We don't really have a lot of soggy data around that. So working as a clinician, right? So yes, you as clinicians, you as researchers, you do actually have unconscious bias that you probably deny, right? So let's go into that. So here are some negative things that we really, really want to correct. So lumping in trans and non-binary issues with every aspect of a client's life is something that a lot of providers do, right? So people will say everything happens to you because you're trans, right? We get misgendered and outed from clinicians and staff. People don't believe that we're trans because we don't look like we are. So when I walk in somewhere and I have to disclose I'm trans, they usually go, so when are you becoming a woman? Or you don't look trans, you look like a boy. And it's like, thanks, like that's not a compliment. And also now I have to like sit here with somebody who obviously is assuming things based on how I look. People ask questions that have nothing to do with presenting problems. So like, how do you have sex when you're at a dermatologist appointment? This is also true for the LGBTQIA community in general, right? People ask me all the time. I remember I had an ear infection. I went to urgent care and they were basically like, do you have a penis? How do you have sex if you don't have a penis? But you're gay. It says on here you're on PrEP and you're gay. And I'm just like, what does that have to do with my ear infection? There's also discrimination around access to services. So people can and will discriminate. Mental health providers can choose not to treat people because they're trans or because they're queer. That's actually super okay, because if you don't have the competency, you can refer out, and people hide behind competency. So what works, right? Be affirming, be supportive, and listen. Have resources and knowledge of community in your area. Talk to clients like they're people, not statistics. Individual power equals the control of our own healthcare, and it can really help us feel empowered. Resilience, right? So build on resilience and have people add the resilience to their toolbox. So, hey, you got through this, you can get through this again, right? That's a tool that we can use. So change the environment in which you work. I'm not going to go over all of these specifically, but it's important to look at like intake forms. So what's on your, like, how do you put your names on there? Alternative family structures. Stay away from using preferred name and stay away from using other, right? So male, female, other. Preferred names are not, like, we don't prefer it, like that's our name. And also when you say other, it means that you're othering us. So a great thing to do if you don't have the ability to list everything is male, female, intersex, not above, right? Or, not here. A way in which to be like, okay, it's not here and we acknowledge that, so please add it. Be aware of space, gender neutral restrooms, not calling clients by the legal names in their waiting room, right? And they haven't changed their name legally. So things like that. And you could take more closer in-depth look at this later. Here's some examples of bathroom signs I think is really important. So bad example on the left, the whatever, just wash your hands, right? It's actually like, it's not whatever. It's really important and affirming for people to use the bathroom that they want to. This is a really good sign, the all gender restroom. If you have the ability to do that, it's just simple, clean, easy, and you can get it anywhere. Let's talk a little bit about an activist approach to affirmative care. So I believe that we're all activists. Every one of you right here, right now, viewing this presentation is an activist because you took the time out of your day to learn about this, and that's activism. So let's talk about the three things. Think before you speak, okay? This has to do even with research, right? If you're putting together something and you're doing interview questions, avoid a patronizing statement. So like, you're so brave, or you don't look gay, right? It's like, that doesn't do anything. It's a microaggression. If you slip on someone's pronoun, don't make it about you, apologize and move on. And also consider the impact behind the statement you're about to make. So if you say to someone, wow, I would have, never known you were trans, what does trans look like, right? Like what's the impact on that? That can actually hurt someone. Think before you assume. So don't assume someone's life is bad because they're LGBTQ plus, or that their symptoms are associated with identity. Don't assume someone's not loved or accepted. And with trans and non-binary clients, don't assume they want to medically transition, because sometimes they don't. I know many non-binary individuals who would rather, they don't want to transition, and their transition is just coming out, right? So it's not a medical step. And the last, think before you ask. What's the reason behind your question? Is this a therapeutic treatment, or are you curious? And your client is not your science project, right? This is not about you. Finally, some activism steps as a provider. So it begins with recognizing your own privilege, which Sunny is going to talk about, and calling out behaviors from others. Individuals from marginalized communities are tired, so sometimes we really need your help. And we're constantly aware of and having to engage with people. It exhausts us. So when you guys have privilege and you have access, use it on our behalf. It's okay. I'm giving you permission. You have the power to start dialogue, okay? You at least have the responsibility to start dialogue, because other people will not. And then use the three things to help guide your activism. Oops. Some final varying forms of activism: find resources, display flair. I love this one. Wear a button with your pronouns, have inclusive art and pamphlets, display flags, attend and speak at conferences. So look at you already being an activist. And help with policies and guidelines. So if you sit on a board and you oversee creation of policies and all that, make sure to speak up for those who are not in the room so that they're included. So putting it all together, you have the power to make change. You have provider privilege, or you have research privilege. So please use it. And we often need cisgender heteronormative individuals to speak with them on these mentioned issues, right? Not for us, but we need you to speak with us, because if we're speaking alone, our voices are often silenced. But when we speak all together, we're a lot louder and people tend to listen. So with that, I'm gonna hand it back over, and I think there will be time for questions at the end. Thank you.
Thank you very much, Jake. Sunny, are you ready to start your portion of our presentation today?
Yes. So I'm gonna put this resource I found for you all in the chat. So my name is Sunny Meter. I'm actually a UCR alum, undergraduate. I graduated in 2012 with a BA in Women's Studies. And then I decided I didn't want to rush to grad school. So I decided to live out what my moral and ethics were, and just to live in general. And that's how it came about working at TruEvolution, an LGBT organization here in the Inland Empire. So we do HIV testing as well. So if you ever need to get tested, it's free. It's a rapid 1-minute test. And mental health has always been an idea that and a passion that I was a part of, but I didn't really start kicking that up in 2018. And thus I left my position as director of advocacy and program and became, care coordinator, and worked my way up to manager. And so what I want to talk about today is structural racism, which is, it is a system of policies and institutional practices and cultural representation that work together to perpetuate a racial group inequity. Those are very fancy words of, the system of oppression works in our institution to deny access to care for individuals. And so I have no presentation for you today. I really wanted it to be free form and to part lecture and then part us talk together, because at some point I would like us to be together and what I like to say, be uncomfortable to a point where we get comfortable enough to be uncomfortable, and that uncomfortable goes away as we talk about racism and how it shows up and where our privileges lies as white people and people of color and Black people. Because being in an academic space as we are now gives us automatic privilege in a way. And it can get hard when you have different intersecting identities, and it can get hard when you think you've worked through some of it. But becoming people who are researchers and practitioners, you have to go through many ways of unlearning and learning racism as times change. And so structural racism shows up in healthcare in various ways. And so this can show up on even a more basic level. Say a homeless client comes through a clinic, and I had one of my clients come through a clinic, and they're like, yo, I just moved from somewhere in the South, let's say Mississippi, and I really want to transition, and I'm just trying to get on healthcare, and I was recommended to come here. A lot of those clients face barriers when they first come in because of how they're looked, how they're perceived, and they don't get adequate care. Just because of that, this client had to come back to me for me to advocate for them to get into care for, you know, what they wanted, which they just like, I just need to get back on teeth because I haven't been on it for a while. And as you know, trans individuals, if they're who are taking tea, if they're not on it for a while, they can become sick. So he just wanted to get back on his meds essentially, and to get into healthcare. And he was already working on a portion for, you know, getting himself off the streets and to, you know, upping his quality of life. I saw him a few months later, all decked out, clean. He was coming in for his appointment. He was looking really good. I didn't interrupt him, but you know, I attend the same clinic as well. So to see him doing well was good. But the fact that I, as a case manager, had to call them for them to get access to the care that they deserve upsets me. And so part of what I want to talk about today is cultural humility versus cultural competence. So back in the 90s, back in the early 2000s, we had a whole bunch of trainings where that makes us competent. Like, hey, I took this training, here's my certificate. I am competent. Look, I am competent. All righty, put me on the field. Let me do it. But, you know, people will say, you know, I'm competent. I took this, you know, training, and I know how this person, you know, experiences pain. I went through the program, and, you know, they like to overcompensate. They're not really in pain. You know what? Black women, they are strong. They are tough. They're not really experiencing pain. And so cultural humility asks that every time you are engaging in your work, that you are self-reflective. And it can be not a painful process, but an uncomfortable process. You're essentially in the moment of every day going, why am I reacting this way? Why do I think that? Why am I doing X, Y, and Z? And where did it come from? It asks you to honestly sit with yourself and be very honest and vulnerable with yourself of why you think a certain way and how you got to that conclusion. And sometimes that can be uncomfortable, especially since you can't stop your own thoughts process, and it will come out before you're even ready to understand it or recognize it. You know, I think this way because I was taught this way by my mother, because I heard my dad say this all the time. And even though intellectually I know that that's not the truth, I unconsciously, you know, exhibit X, Y, and Z. So how do I fix that? Right? How do I fix that so it shows up genuinely? So it doesn't just show up as, you know, me saying, oh, I'm sorry, I understand that's what you're going through, and this is what I have done, you know, to make sure you feel comfortable. Because clients can hear that all day. Doesn't mean they actually believe you. But the ways that you can find that the words that you convey to your clients are actually true is if you have done the work, and you will know it will feel different when you actually say it. It will show up different on your body. I also move all over the place, so I do not mind if you interrupt and you have a question. I would like you all to be engaged with me, because as I said, I don't have anything concrete for you all. And so some examples of structural racism that has shown up is that people don't get access to care, not access to medication management, not access to pain management, not emergency care, not insurances, not even, you know, in some places just to get a test. The one I'm most upset about is medication management and pain management. A lot of people of color and queer and trans people of color don't go to they don't go to the hospital at all. They don't go to the hospital, don't even look for a doctor because they think it's easier just to sit and bear through the pain than to go to the doctor and experience that whole, ordeal of being misgendered or assumptions based off their sexuality, having to teach their physician, their clinician, whoever is giving them services in the moment, and then in that moment becoming the example and they don't get the care that they need. Because after like 30 minutes of me telling you and explaining to you what X, Y, and Z mean, I just want to go home. I came here for, something else, something that had nothing to do with my sexuality, nothing to do with my gender, nothing to do with my gender expression. And yet here I am teaching you about it. And now I'm uncomfortable, but I'm too uncomfortable to say I'm uncomfortable and I'm ready to go home and I have to do it over again. I spend a lot of time with my clients trying to convince them to, not only get their insurance, but to choose a primary care doctor. So it becomes a large responsibility for me to find primary care doctors who are not just competent, but who have humility. At the end of the day, it's not about you. When the client comes to see you, they don't care how you feel. They don't care X, Y, and Z. They care about how well you treat them. And essentially, the client becomes, um, what's the word I'm looking for? I want to say master, curator, the poet, the writer of their experience. They tell you, this is how I'm feeling, this is what I'm going through. And even though you may have a plan for them, that might not work out. So, for example, I had a client who wanted to get housing services, they wanted to get an income, and they wanted to transition. And I foresee that for their care plan that they needed to get an income, housing, and then transition because the space that they were in was not contributing to their overall mental health, and it was disallowing them for finding income and housing. So I, assessed that the income and housing was the most important before the transition. The client did not agree. The client said, this will not work. I feel I need to transition first for this all to work because I feel that that is the issue. The client went ahead and transitioned and had everything else fall into place. So I tell this story to show that, knowing what the client wants and what their story and what they have assessed the problem and the pain is and addressing them alongside with them is going to get you further than telling them, this is what I think it is and this is what we're going to do. And so I do that now, even though I would talk to a client, I go, oh, you need X, Y, and Z, but what do you think you need? Okay, maybe we can get to my X, Y, and Z later. Let's fix your A, B, and C. Let's do some solution focus, some strength-based therapy. I'm a social worker in training, so those are my terminology. I'm sorry. Um, and so it's always imperative that you talk to your clients first and see what they need and what was that? Sorry, stuff is falling down in my room, scared me. What they want. And then lastly, I want to talk about how because of people's biases, their consideration for a person just gets thrown out the window. You don't even consider the person enough to even think of asking them just basic questions that is considered for them as a person, as a woman, as a man, as a trans individual of all genders. I was fortunate for the last 5 years to have a very humility-based position. I didn't go to the doctor. I haven't gone to the doctor for about 7 to 10 years because every time I went to the doctor is because I was overweight. I was overweight and none of my pain meant anything. They always forget my pronouns. I'm trans-identifying, non-binary, but that was never the case. They would always say my dead name, even though I go by Sunny. And even up to this day, the people in the lobby versus my doctor is very different as well. So always making sure that the staff you work with are also up on the same speed. And so, my question is, how do researchers create practices that have consideration for QTPOC? How does your care show up day to day? Something to think about. And one that's practicing cultural humility, it's working with your internal bias and assumptions as a daily practice. And make sure you take breaks. Every day onslaught of going, oh my God, where do I have to unlearn today? Can be very, a lot on the soul, a lot on the mind, a lot on the heart. And it, like I said, it takes a person to be vulnerable, honest, and intimate with yourself. You can keep a journal. Find the people that you love to validate and to work with it through you, who's going to hold space for you, who's going to hold you, especially if you get to a point and you realize, excuse my language, how fucked up some of your thought processes are, and everyone has them, because structural racism is all about systems of power, you know, and each power is different depending on each country. But in the United States, at the top of that power is heteronormative white men. That is at the top, and they dictate everything down. Um, and then research and gather data. Who in your field is already doing this work to decentral structural racism? Learn from somebody who's already doing it. It's going to take you all to be trailblazers because it hasn't happened before. And, you know, I'm hoping after this conversation today, as you all graduate and move up the ranks to being researchers, that you fight for the change in language that's being used in research. I find that in the medical field, mental health as well is usually 10 years behind. And as Jake and Joshua has said, like language changes all the time, which I'm quite excited about because that means I get new terms to identify. I'm quite, excited for Z generation and A generation to just tell me, you're old, grandma. Your stuff is outdated. Oh, tell me how I'm outdated. I'm ready. Give me new terms. How can I identify? Queer doesn't work anymore for these younger generations, though I'm a millennial, so queer works for me in a very various ways. But the Z generations are like, we're not using that anymore. That does not work. Why are we using queer? No, it's a no for me. Fair enough. So the last thing I want to say, I keep saying the last thing, but I keep forgetting I have notes over here. Language is important. Knowing how to use it and when to use it is going to be important. So the one thing I wanted to highlight today is the terms racist and prejudice. They're being used wrong in society today, which is not, not an accident. It's done on purpose. So the way that dominant culture continues to have dominant control is convoluting language. And so if racist and prejudice are misused, then they can continue to say, this is what a racist is. So how can we all be racist if, everybody else is calling each other racist? Where in this country, the only person who can be racist is those from dominant culture. And those who are not from dominant culture can only be prejudiced towards each other. Because racism denotes a power exchange, correct? I have to be able to have power over your life and change it by my existence for me to be racist. But I do not have that privilege. I do not have that power. So thus I cannot be racist. I also can't be sexist, but I can be misogynistic. Knowing your terms and your definitions and how you use them in research is going to be very important. And it's going to be very important how you use them in community when you're talking to community as well. I had to get off Facebook at the beginning of election because people were using racist wrong. And I was getting into arguments, something I had promised myself to never do on Facebook. I was getting into arguments with people because they were using racist wrong. And I was like, no, you're talking about prejudice. That man is prejudiced. That's why he attacked the other man. He's not racist. He doesn't have the power to be racist. That's not how it works. Delete. I had to get off of it. And it's slowly showing up on Twitter. And I'm just like, you all are using it wrong. And this is how the dominant culture stays dominant. If they can change the language that we are using to explain the system of oppressions and the inequalities in power, then they can continue to have control over the narrative as well. So language is really important in that way, and also having cultural humility and understanding people's different backgrounds from different dominant cultures. For example, I'm going to use Japan. Japan's culture, the dominant people are Japanese people. But when they move to the United States, they're no longer dominant. So how does that work for them as they come to terms with no longer being a dominant person who has power and privilege in the United States, but when they go back to Japan, they do. That's also a conversation within, the cutie pot community. So, cutie pot people have a triple layer when it comes to accessing healthcare. They already have people who are humans are curious, but you need to know a time and a place when you can ask someone some intimate details about their lives. And it's never okay to ask anyone details about their genitalia unless they're comfortable and they offer that up themselves. And so it's still a battle today to get a lot of my cutie pot clients, a lot of my trans clients of color, specifically trans men of color, Black trans men and Latino trans men to go to the doctor because it's just easier not going. And it's easier not to get a pap smear because that is still part of their health and overall health. So as researchers, how you structure your language, how you do your interview process, it's all going to be important to take in these considerations. I had a brain fart and kind of completely stopped there at the moment. So I know we have questions, and I know we have probably like 45 minutes, Jacob. but that's, you know, the passion. So I don't mind, as we're still on this topic instead of the overall topics that we talked today, if anyone have any questions or they want to talk about something with me specific to structural racism, I am open to doing that right now. Or Jorge, because Jorge is the director of programs and he's here in this meeting room. I'm just gonna call him out. He's been with us since the beginning too. Hi, Jorge. I do not have anything else. If no one has any questions or comments or anything they would like to engage with me. Oh.
I have a question. I'm a fourth year medical student, and I love my social workers and case managers. You all do some amazing work, and like the world would like stop running without you guys. But I think so. Like, what's something that that we can do as providers to help this like linking process for your like trans non-binary individuals that you have on your caseload? Like, what's something that we can do to outreach to you and support you in your work?
One, outreach. I know sometimes your life gets busy as a physician, and I know you're a fourth year, but I know plenty of physicians who are busy, but incorporating into your daily work plan, I don't know why I'm going to use that word, but I'm going to use that now, where you do something that social workers do, and that's community-based involvement, and that's reaching out and figuring out who in your community can service your clients. And usually that is just left to the social workers. And I think at some point, you're just going to be too busy. So your relationship to your social workers is going to be important, because they're going to also teach you the language that you're going to need and understanding, because clients tell you different than they tell me a story different than they tell their therapist. So to go on a tangent, I have a client that'll tell me a whole bunch of stuff, then they get to their therapist and they say nothing. So I have to talk to their therapist. This is what's going on. Wait till they tell you. But this is where you might have to have some humility and wait for them. And it's the same way when I'm testing someone for HIV. They just want to know if they're negative or positive. So they'll come in and go, I don't know what happened. And then they get their result and they go, girl, I was at a threesome with my boyfriend and they tore a little bit. And I just was, I was just, so stressed out at what happened. And we weren't using condoms. And girl, I don't want no condoms. We don't use no condoms, but I'll just come back and get tested. Your best bet is to know your resources and to develop your relationships to the people in your community. For me, that's always a big thing, even to different types of people, not just to social workers, but to LMFTs. I think we're greater together than separate. And in your LPCs, and your nurses, your nurse practitioners, the stronger you can make your team, the better you will be able to capture people who might fall out of your care. And keep making sure you all stay on the same page. And maybe a little bit work when someone is like too uncomfortable and they're messing up a lot, and then figuring out, I don't want you to be in trouble, and I want to know what's going on. Those kind of conversations can be really helpful. They're really uncomfortable, but they're really helpful if you get, say, someone who's a therapist or who's a nurse practitioner who's just having a hard time, and they can be just as honest and saying, I just don't like doing this. Okay, you don't like doing this. How can we get you to do your job effectively? Because I don't care if you don't like doing this. This is literally your job. This is what you signed up for. So how do you get to a place to where you can do your job effectively, regardless of how you feel? Did I answer your question?
Yeah, no, totally. Thank you.
Okay, cool.
I actually had a question too.
Yes.
So I'm currently a med school applicant, and I'm also a behavioral therapist.
Okay.
And one thing that I've encountered in the field as a behavioral therapist is a lot of my clients have a lot of ignorant views, and some of them, they're so young. I mean, they have autism, and they kind of latch onto whatever their parents tell them. And sometimes I feel that some of their comments are super, super ignorant. Like, for example, I've heard like one of my clients, and this client is 10 years old, say, oh, the Chinese or whatever. They say something like that. And, I obviously am shocked to hear them say that, but I know that they learn it from their parents. My question to you is, how would you best educate a client or even a patient, since I want to go into the medical field eventually, how would you best educate a patient or a client to, I don't know, best navigate the world and, maybe have better viewpoints and have a better way of expressing their sentiments, if that makes sense?
I think the best part about being a behavioral health provider is that you already created space for them to explore
Mm-hmm.
those misconceptions. So I
Mm-hmm.
guess my question is there something that makes you too uncomfortable to take on that role of education for your younger clients?
No, I don't feel uncomfortable at all. I just wanted to see if there was an even better way for me to
Got you.
approach that, if that makes sense.
I mean, when it comes to children, the issues usually is the parents.
Mm-hmm.
But the unique thing about you being in their life at that moment is that you get to observe the parent teaching. Because a lot of the stuff we learn from younger is just by watching our parents, and then they realize they taught us unconsciously. So for me, and Jake, you can also chime in. There's not a best practice more than just to do it and to take some time and say, well, why do you think that? And actually doing the exploration and introducing the different types of thoughts and ways that people exist.
Okay. Okay. Thank you.
No problem.
Yeah, I would love to add to that too. As somebody who is trans and sometimes works with family members or works with individuals and they have really horrible language and they're trying to do it to upset you, sometimes putting yourself out there if you feel comfortable is a really great way to help combat that. So especially kids, because kids are very well. Autism, it's a little bit more difficult because of the emotion, the ability to understand and read emotions. But for kids who I guess are not on the autism spectrum, it would be something like, okay, hey, you know what? When you say something like that, it really hurts my feelings. And I'm not even like part of that culture or that community. So, I can really imagine that like if you said that to somebody who is, they might hurt too. What do you feel about what I just said? Right. So, I always stay away from whys. Like, why did you say that? Why did you do this? Because whys keep you up in your content rather than your process. So you go, what about that statement? Like, what made you want to say that? Or what about that statement is true to you? Or what about what I just said? Right. Like, hey, that made me feel uncomfortable. Right. What about that affects you? So bringing yourself sometimes into it, even if you're not part of that culture, helps to teach like that bothers me, right? You could be bothered by other people's views of other people's identities, right? If that sort of makes sense. And it teaches
Okay.
this idea that that like even if you're not part of that community, you could still stand up for it, you could still be mindful of them, and you can still be conscious of the way in which you interact. So with kids, it's like I said, it's pretty much that moment where you're like, you hurt my feelings, and they're like, I'm close to you and I don't want to hurt your feelings, and they'll be open to wanting to have that conversation.
Okay.
Most of my
Thank you.
experiences with younger adults, emerging adults, I don't have much experience with children.
Mm-hmm.
Per se, children are like a wild card to me because they're learning how to have boundaries, they're learning how to have respect for people, and they don't. And I enjoy them for it, but not in a capacity when I have to deal with parents. If I'm going to be completely, totally honest, parents are usually the issue I have, not the kids,
Mm-hmm.
because it's literally not the children's fault. They're being taught and raised, and they're someone's responsibility. So I can't really hold them responsible for the stuff that they actually understand and stuff like that. So I usually hold
Right.
parents at fault, but parents are unwilling to say they're at fault because they want to always think that their parenting is top tier. And
Mm-hmm.
parents are about their idealized parenting, and they never, not many, but the ones that come across never make room for to assess and to look at their parenting to see if it's actually going well, especially because
Yeah.
each kid needs their own specific kind of parenting. That's why it makes parenting and having children hard, because there's no one way to raise a child. Children
Right.
scare me. I'm just gonna be completely honest, and that's something I need to work on each day.
Yeah.
If no one else have any other questions,
I have a question, uh,
yes.
and this is to the panel, and thank you all so much. Um, what about older uh, folks? seniors, and what kinds of issues do you run into that you don't with younger people, or are they the same? Can you speak to that?
Yeah, if you wouldn't mind, Sunny, I'd love to jump on that. That's where I did most of my training, actually. So most of my training for my clinical hours was with cisgender gay men who are HIV positive over the ages of 60. In the queer community, we consider our elders about 50 plus. That's just kind of like the community joke of standard. But the way in which I saw them, it was the way in which we approach that, we have to approach from a model of working around guilt and shame, because a lot of the issues that follow, even going to the doctor, right? And being like, hey, I want to get in, I need to get anal swabbed because I have anal sex, or hey, I would like to go on PrEP, or I need to talk about my HIV medications. There's a lot of shame because when they grew up, right? Think about some of them in the 50s and 60s were teenagers during the AIDS epidemic, and all of the media that was around there and all the things talking about how, you know, they're going to burn in hell and AIDS is a gay, you know, a sin disease. So the compounding trauma is just so there. And then when you work with the trans and non-binary community, I actually know a lot of trans women who've transitioned like in their 50s or 60s, and they're bringing along the fact that they have families, that they have spouses that they were married to, and they feel like they made this horrific change in their family, and they've upset everyone, and they feel like they've sacrificed, when in all actuality, those are a lot of things that they're projecting. And most of the time when I've worked with clients, their families are like super supportive, and maybe they don't stay together, right? The spouse, but they're really good friends and they co-parent. So there's a lot of this projection. We call it, oh my gosh, I can't, internalized rejection, where they just think that they're going to come out and their life is going to be terrible. So the big difference in elders, I guess, in a short summary, is this idea that the second you come out or the second you tell somebody, your life is just going to be turned upside down. Whereas with youth, what I'm seeing is like the resilience, especially of Gen Z. They're like, yeah, I'm out. I don't care. I don't have shame. This is me. Like, yeah, I'm going to go have sex. Oh, sex positivity, wear a condom, get so it's the big difference of like shame. I would love to like actually pair up. I had this idea of like a grandparent program, although like most of my friends would be like, I'm not grandparent age. I'm like, I'm sorry. Okay. Mentor program, but more for like the older queer people to learn from the younger queer people. Because there's a lot they can learn. And yeah. And then the one last thing I will say is with elder queer people, there's not a lot of community or family around to help take care of them when they get to a certain age. So you see a lot of time, especially cis gay men who lost everyone they loved in the AIDS epidemic, that they're 75, 85, going into homes. They have to actually go back in the closet because the homes aren't supportive. And then they're basically finishing the rest of their life unaffirmed. So that's a big one that we see too. So sorry, I get super excited when we talk about elders because we don't have anything, like not even research or data. So like my passion.
I would just affirm, Jacob, it's the same I had, it's the same what I see in elders. We have a few support groups at our place, and one of them is just filled with elders who are HIV positive, mostly cis men, and it is in Latino, so there's a lot of deep shame and machismo that they're working through when it comes to being out, and if they aren't out, they're still in the closet because they're living with family on top of being HIV positive that's connected to being gay. And so there's a lot of shame to work through. My history working with trans women specifically is that they are self-projecting their own, like, I forgot the word you used, Jake, but yes. But I also, a lot of them are all like, I waited so long just to be me. I don't care anymore. I'm going to be me. So there's a lot of resilience in that way for the older trans women that comes through TruEvolution, at least, is that, thank you. I appreciate you. They are still working through what they left, but they're mostly working through what they gave up. So specifically, this person was moved a lot, and decided to live their life as a man for a long time because it was easier because of the abuse they endured when they were younger, because their family was very heavy on them being and acting like a man. Even though they had instances where they were like, I was a girl child and I wanted to do girl things. I wanted to play with dolls. I wanted to dress up with this. And though my mom let me be me when my dad wasn't around, it was not possible for my dad. And so for her and her story, it was more like, um, you know, I have some shame and I have some rejection and I try to keep up with my family, but at the same time, I waited very long to just be me. And for some trans men as well, it's the story that I hear is that I waited too long to be me. And now here I am 75 and I just got top surgery. And let me talk about it for a very long time, how I got top surgery. And I'm about to get bottom surgery and they messed it up. And so now I'm going to go and sue this person. How I got, voice female feminization surgery, where they shave off the face to make it a little bit more feminine, or they do like a voice therapy to make their voice seem more feminine. They're really excited when these milestones come, because essentially transitioning is another puberty. So they are having like their second or third puberty very late on in life, and they're excited about it, but they're also very sad about it because they also, like Jacob said, they don't have many community members that they can, lean on, and they have to do everything by themselves, and they're getting older. So that's what I want to add to that question.
And from my perspective, doing research among trans and non-binary clinicians, when it comes to elderly trans people, a lot of the time they are operating using language that might be 10, 15, 20 years old. And so what happens is sometimes you have cis providers that have taken cultural competency classes or are trained in the contemporary language associated with queer community care. And you have these cis providers who then start policing the language of older trans people. And then that stigma attaches to them, where they feel as if they are an inadequate trans person and an inadequate queer person. They feel bad about themselves because words that they learned as they were growing up, or words that they started to claim 20 years ago that might not necessarily be the language of today, but that language speaks to their experiences, is now allowing them to be policed by people who are not part of the community. So there needs to be these, based upon my research, there needs to be these translation, cultural and generational moments of translation where these conversations can happen in an affirming and open way and not in a regulatory or policing way.
My favorite is talking to elders in our community as they're learning, because at the end of the day, they're still elders. They still have their own language. They still have their own timeline that they grew up in. They're still older folks that needs teaching from a younger generation. And I'm no longer considered a younger generation, even though I'm only 30 and I consider that very young. There's still a very younger generation that's dictating language and how things are moving. And so a comparison to answer your question, Keith, is to celebrate them using the language that they learn and stuff like that. And sometimes I like to do, like, a client will gloss over something that took them, that was very super hard for them to do, and then they'll just keep talking about it, and I like to go, wait a minute, I want to go back and celebrate you just said you did X, Y, and Z, like, congratulations, that was a lot. And sometimes they don't even know to stop and celebrate, so they're excited about it. Having someone who's a practitioner or someone on the medical side to also celebrate them in a milestone is also important, and things like that. I had somewhere I was going that I had a brain fart. But
Yeah.
yes, watching elders learn language is really super fun. My granny is going to be 76 years old this April, and we have conversations all the time, especially around trans kids, because she was confused, as she should. You know, she was a nurse, and so she's all like, "Can a trans kid know that they are X, Y, and Z?" I was like, "If you can when you were younger, how can they can't?" And she goes, "You right. You're absolutely right." She's like, "An old dog can learn new tricks. Don't say I can't." That's always my grandma's motto and stuff like that. So when she was an adult, it was lifestyles. I'm not a part of that lifestyle. So when women hit on my grandma, she laughs and she goes, "I'm not a part of that lifestyle, honey." Though that is an outdated term to use. And I tell my grandma, but sometimes she forget, at her time that was acceptable to use. But it's always my favorite thing to talk to her and see of the queer community during her time what was used, because she was young, going out and partying during disco era, during the 70s. So I really want to know, because that was fabulous era, for queer culture, and history.
I want to also answer to Keith's question about how we can help trans folks celebrate milestones. And so when I do my individual therapy, I also do a lot of coaching for trans individuals. I make them do I call it a transition roadmap. And so I'll be like, okay, I call it a transition timeline. And I make them do it first without very limited instruction, right? Make it how you want to. You could draw it, you could type it, do whatever you want. And they usually come back and they bring it. And on the timeline, it's usually just medical or like social gender transition related stuff. So like, I want to get, start HRT, go on this, come out to my family and friends. I'm like, that's great. Like, that's an awesome thing. But here's what you're missing is like all the other milestones in between, right? So like your transition timeline is not you necessarily transitioning from one gender to the other. It's like you're transitioning in this time in your life. So put other milestones in there. Like I know you've talked about wanting to go back to school. So where do you feel like putting that in your transition timeline? Or like, I know you've talked about wanting to get a dog, right? Where do you want to put that in there? And then it really helps to put it on a roadmap. And then sometimes I'll be like, go get that, laminated, or go make copies of it, put it on your wall. And every time you hit it, mark it off and take a moment to celebrate that. It really helps to have something out there. And out of all of the sort of like things that I do when someone comes to me, for the first couple of sessions, that's the one that they really take with them like years down the line, just because it's a way to celebrate even internally. So I love that one. That's a fun one I do.
Additionally, to add to, I'm thinking of teens who want to express their gender that's not in normative ways, like just to be very binary, girls who want to wear boys' clothes and boys who want to wear girl clothes, to give them those names. Those are not adequate ways to explain those, but affirming that they want to wear those clothes and that they will look good in those clothes and that they have the courage to wear those clothes. I'm thinking of preteens, those in middle school who are exploring their gender and their gender expression and what it means to them. And not necessarily their sexuality, because some person can present a completely different way and have nothing to do with their sexuality as well. And those are some of the heaviest conversation I have with people, even when they get older, when they're like, my gender identity and expression doesn't meet my sexuality. And I have a problem with that because I want to fit in. And having that conversation, that it doesn't have to. And you can exist totally as you are, and it still be okay. And if, the people around you are not affirming that, we can talk about it down the line, but we can talk about what you expect and want from your friendships and how it's reciprocated, because that's important too as well. If the people are not affirming of who you are and what you bring to the space. Popcorn it back to Joshua.
I have a few more things that I could add to the general workshop to kind of wrap us up a little bit, but I didn't want to interrupt the flow of consciousness, if you will, that we are currently engaging in. So if there are any other questions, I wanted to speak before I dive into talking a little bit more about applications for research in health. Please, and then there'll be more time to ask questions after I kind of finish out my spiel, but if there's anything else that was in direct reference to what Jake and Sunny was just saying, please by all means ask. Okay, I will take the silence as a green light for me. I'm gonna go ahead and share my screen one more time for just my final slide. So in thinking about what we've been learning today, in the wonderful and insightful discussion that really has been spearheaded by Jake and Sunny, I want us, for me as an anthropologist who's finishing dissertation research and currently writing my dissertation in the realm of trans health, I want to think about what are some takeaways for researchers in terms of cultural competency, or as Sunny has said, cultural humility. So knowledge in LGBTQIA plus competency or humility allows health researchers to be mindful and cognizant of the intersecting oppressive systems impacting LGBTQIA plus patients and clients. Structural racism, transphobia, homophobia, misogyny, transmisogyny, heteropatriarchy, capitalism perpetuate targeted bias and violence against LGBTQIA plus people. The lasting legacy of unequal treatment and blatant harm experienced by communities of color, as well as queer community writ large in healthcare institutions, as manifested in a climate of distrust and fear. The intersection of sources of marginalization and societal abjection perpetuates these health disparities. A grounded understanding of the interpersonal and structural inequalities facing these communities can better inform research, contribute to positive rapport with participants, and improve the quality of collected data that will then improve the quality of results and are also the quality of our capacity to share those results with communities. Researchers committed to engaging with communities facing intersectional oppression will be better equipped to represent narratives of experience, and will do more to inform healthcare professionals and institutions of care and how to mitigate these persistent inequalities from an affirming and culturally competent perspective. So with that being said, let me stop sharing. We do have a little bit more time for an expanded discussion or conversation or even questions concerning these themes. So if anyone else from among our attendees would like to talk more about or ask questions about or engage about applications within clinical practice or applications within research, I think that we have time and we're more than open to exploring that further in our few last remaining minutes.
I guess I have a quick question, something that I was thinking about when you're talking about like linking your trans non-binary patients to care. Is there like a working list within Riverside County or San Bernardino County for like providers, primary care providers, or just I guess any providers that are like have cultural humility within this for this population specifically?
There isn't, though we at TruEvolution keep an internal list of people that we send them to. Usually is mostly Borrego for PCPs, specifically the East Side Health Center that is down the street from the university. Most of the people at TruEvolution go to this clinic because they're so affirming. There are some clinics around Borrego that aren't as affirming, specifically the San Bernardino clinic. They're still working on it. And the reason why I say Borrego specifically for PCP is because they have an internalized trans health medicine department that is focused on trans healthcare and mental health care. And that is why I also recommend them. So they also have a specialty clinic out in the desert. I don't know where in the desert. I'm actually originally from Oakland, California. So I still have some, problems recognizing where in the desert, because I consider this all the desert, but the specialty deserts like this Cathedral City and stuff like that, to go on a tangent. In terms of mental health providers, that list is slowly still growing. I know there's us, there's Jacob, there is one other person whose name I'm forgetting, but I say it short because people are in school are gathering like experience and haven't, entered their practice in the Inland Empire specifically. I know there's also Sakura Counseling out in Fontana, to name a few, but most of them are centered in large cities like LA. And so when we don't have the resources and it's easier for a client, we send them to LA, especially in previous for prep services and housing services and stuff like that. We send them to the LA LGBT Center, but that, can be a detriment if they don't have, money or transportation and stuff like that. There's also Rainbow Pride Youth Alliance that deal with youth specifically in San Bernardino. Yes, there's not like a place where you can find all this information. This is literally like years of community work and stuff like that. So if you want a list, I'm gonna put my email in the chat and you can email me and I can create one for you. I think that would be the best one. And I'll bother Jorge to help me with this list. I'm just gonna bother him throughout this whole meeting because he's here just watching me.
Great.
And it really, sorry, go ahead.
But I just wanted to say thank you.
That really speaks to the patchwork that trans health represents, especially even in California, right? I do know that out in the Coachella Valley, you have Eisenhower Health, a medical center that has trans services, Transgender Health and Wellness Center out in Cathedral City in Palm Springs has some services as well as like referral programs. And a lot of those programs also do referrals out to Los Angeles, just because there's the established capacity for affirming trans care in LA while it's still growing in the Inland Empire. So, one of the parts of my research is to one of the broader impacts of my research is I'm able to facilitate some of the connections between providers that kind of are disparate across, because my field site is Southern California broadly. And so being tasked with talking with folks in LA and Riverside, it's really cool in that it can start connecting people together. Jake's in LA, Sunny's in Riverside. So I think even just this workshop represents the potential for having greater connections to fill in some of those gaps of that patchwork.
Mm-hmm. So if you want that list, someone has to tell me, or I'm assuming no one wants it, and I'm not going to create it. So if you want it, email me or let Joshua know. See if we can give it to you all on a bigger, larger scale. The only thing I will say that with the Inland Empire, you must call periodically. We do it every quarter. Like yearly quarter, because resources come and go, or the people who work there come and go. So that's the one thing about the Inland Empire, is that you must call and see if they still giving the service, and if the person who's giving that service is still there, and if they have a new person, what their contact information is. That's the one thing about the Inland Empire, or just in rural communities, is that you always have to stay up on your community resources. I think it's about time we audit our community resource list, which is in the making right now. It's a few pages long, but
Joshua, do we have any clinical medical doctors in our own UCR medical school from any of the facilities you talked about?
There is Jamie Woods. Dr. Jamie Woods is a psychiatrist, and she's trans, and she was hired last summer, and she works for our medical school. Okay. Yeah, and that's the only person that I know at UCR, and I could be wrong, there could be more, but just in my own networks, people that I've talked to, yeah, she's the only person I'm aware of.
Yeah, and I'm wondering to what extent is this information put into the medical education for our students?
So I didn't know that, and I'm a student.
There you go, Jennifer. Okay, now we know.
Are there any other questions or comments? Anything?
This is really great.
Thank you.
I will continue to talk, if you let me, about any and everything and nothing else. It's one of my superpowers. I will go on tangents for days. I have a lot of stories. My clients are fun and funny. Kind of miss them. I haven't seen them in a year, so.
The casualties of the pandemic.
Yeah. They call me randomly. Sunny girl, where you been? I've been at home working. What you need? Nothing. I just want to talk to you. Okay, cool. What you need to talk about?
Well, if there are no other questions, I know. Oh, you're so welcome. Thank you so much for all your participation. I really appreciate everyone's willingness to be here and to listen and to engage. It's been wonderful. If there are no other questions, I know that I think we're just about somewhere close to being out of time, and I definitely want to allow everyone to stretch their legs and be able to recharge for the next session. So thank you very much. Have a great day, and please be in contact with any of us if you have questions or want to continue the conversation. There are resources on the Expo Pass that are based on what you saw today. So please check that out. All right, thank you.
Thank you.
Thank you very much.